Alrighty. So, hello everybody on this miserable day in Sydney, but hopefully lovely where you are. Welcome all to hear the seminar from Dr. Nicola Gates, who is clinical neuropsychologist of over 20 years experience. She's worked both in the public and private systems, and she's very actively engaged in the forum with education and with keeping the standards of the profession high. We are so proud to have her working with us at MAG, and she is actually giving us regular availability on the MAG calendar in the new year. So that's very exciting for our clients. So today's seminar promises to be very interesting and very topical in relation to the claims that we see coming through more and more. I beg your pardon. So anyway, without further ado, bit of housekeeping first. So if you are choosing to keep your camera on, which you're more than welcome to do because we love to see your faces, would you please ensure that no one in your home or office comes into the room and decides to take their clothes off, because that did happen in one of our seminars, meaning that we could not use that recording. I can mute your voice, but I can't mute your camera. Also, I'd ask if you could please keep your microphone muted until question time at the end of the session. The reason for that is so that noise in your office or home doesn't cause interference or drown out the sounds or any feedback. So if you could do that, I'd really welcome that. Thank you very much. And without further ado, over to you, Dr. Nicola Gates.
Okay.
Host.
Hopefully, we're just trying to hand over the screen sharing.
You should be able to do it now.
Right, we all on?
Can't see your screen yet, can still only see your lovely face.
Okay, so whereas I have got, okay, so let's go back. And what about now?
No.
Okay, everyone hold tight. This was all working beautifully in the practice. 1 second ago, I'll just start again with the clicking the share screen. You've enabled it, so I don't know. Let's go. Let's share. Let's go.
Yes, it
now.
Started now. Beautiful.
It has? Okay, perfect. Let's go. So I'm really here to talk about persisting symptoms after a concussion and why terminology matters. And I do apologise in advance. I probably do. I have a little bit of a bee in my bonnet about this, because I'm actually seeing harm occurring. And I'll describe later, I've always wanted to do myself out of a job. I've spent a lot of time investing in the prevention of traumatic brain injuries and acquired brain injuries. And I'm seeing harm being done. So I think the terms matter. I've already been very kindly introduced. I've been working in traumatic brain injury, predominantly in acquired brain injury, for 28 years now, starting in a brain injury unit here in Sydney. Fully qualified, registered with CERA and so forth. Prior to Netflix, I found there wasn't much on TV, so I also wrote a couple of books encouraging people to look after their brains. So let's get to the topic at hand. I want to present persisting symptoms and why it's important to move from post-concussive syndrome. And I really need to acknowledge the work here of Donna, who is a member of the International Neuropsychology, like myself. And she was the clinician, I guess, who gave me the, in her presentation at the NAN forum, gave me the big elbow under the ribs to really review this topic and take on board the new terminology that was being used internationally. And I want to look at the factors that are impacting on people's presentation and briefly to talk about management, although that's not really the purpose of today. Terms matter, and these terms absolutely impact management. So to begin, I want to say something that is the obvious, but unfortunately it's not that obvious, based on some of the referrals and the reports and opinions I see from other health professionals. Not all bangs to the head cause a concussion or a mild traumatic brain injury. And I think that's really important to remember. particularly because of what we know that is going on for a lot of people who develop persisting symptoms. Some people are highly suggestible. And I'm going to give an example. I saw a woman who was out of employment because of her persisting symptoms for 18 months and believed very strongly that she'd had a concussion because she had symptoms. Now, she was hit on the head by a pencil, no bigger than this, with a ping pong ball on the top with a smiley face on it, thrown by a 3-year-old child in a childcare centre. And the stick was called a talking stick. And the child was 4 metres away from her. Now, I don't think anyone on this forum would consider the physics involved in being hit on the head with a ping pong ball on a equivalent of a plastic chopstick would result in a traumatic brain injury. But when I saw this woman, that is what she believed she had. And a number of people had said that she had a mild traumatic brain injury / post-concussive syndrome as a result of her presenting symptoms. So we know the brain is significantly protected by the skull. It has CSF fluid around it as well. So, you know, hitting our head, getting into the garage, which is something I do, unfortunately, way too often, is not necessarily going to result in any of the things that we're talking about. So we need to just step back and remember that. So there is obviously evidence of a head injury, and objective markers are the Glasgow Coma Scale, so any change on that scale. And I'm talking to an audience that knows these terms, so I'm just going to go over them briefly. Duration of post-traumatic amnesia, and of course there's SCATs. So SPECT scans. So we know that there is objective evidence that there has been an injury to the head, and there are a number of symptoms. Now, the issue with post-concussion syndrome is that a syndrome, by definition, is a set of medical signs and symptoms that are associated with specific disease or disorder. So you think of something like metabolic syndrome, which we now know is a significant health burden on society and contributes to a lot of our profiles of acquired brain injury. So we're talking about obesity, objectively measured. We're talking about hypercholesterol. We're talking about diabetes type 2. We're talking about hypertension. Now, those are all objectively marked, very clear signs, and they go with a specific disease note or disorder, syndrome, metabolic syndrome. So we all know what that means. Typo. The problem with post-concussive syndrome is the symptoms are very subjective and they are non-specific. Now, there was a presentation a couple of months ago, and that presenter found that the diagnosis post-concussive syndrome was helpful. And I'm saying I completely disagree with you. It is non-specific and doesn't really mean anything other than that person's got lots of symptoms. And that's why it's recently been dropped from all the diagnoses. So there is lack of specificity in post-concussive syndrome. So if we talk about the various symptoms, and again, I know that you're a learned audience, but let's think of some of them. So somatically, headaches, dizziness, tinnitus. If someone says they've got those, you might go, okay, they bang their head, oh, something's happened. Cognitively, they say they've got reduced attention, they're distractible, they've got memory problems, they're not as fast as they were, and they might psychologically feel they're anxious because of their head injury or their concussion. They might be irritable and depressed, and everyone looks across the horizon, sees the top of the iceberg and goes, bang their head. I am saying head, not brain injury, and they go, must be concussion. It's happened after that. It's post-concussive syndrome. However, let's flip and look at this another way. So we're going to flip the iceberg and look at other things. So there is no specificity. So you get headaches, and because women are overrepresented, or rather I should say this, the biological sex female is a risk factor for developing persistent symptoms, and so is age, but women are overrepresented. Let's think about what's going on for women at mid-age, because we know women in mid-age and going through the menopause transition are actually overrepresented in lots of different conditions. Menopause, you can see that. Menopause is associated with headaches, dizziness, tinnitus, attention problems, memory problems, slowed information processing, anxiety, depression, and irritability. I'm in menopause. I'm not being critical of women in mid-age. I've written a book on it. We know there's a lot going on. Studies through COVID and studies looking at people on Zoom, doing Zoom meetings, indicate that there is a high report of these same 9 symptoms. So there is nothing specific about having these symptoms that should automatically make people infer that there has been a concussion, mild traumatic brain injury, or symptoms persisting. So let's flip the iceberg and look at all the other things that are going on. And we are sophisticated now. We actually understand the biopsychosocial models of a lot of conditions, including chronic pain. And so research has shown that control subjects with no concussion report symptoms that are associated with concussion. So that's 31%, which is exceedingly high. At the same level compared to those of 38% of those who sustained a concussion. So clearly these symptoms don't really mean anything helpful. And the terminology, there is research that suggests that the terms lead to a sense of resignation and helplessness and hopelessness. And my concern, based on the referrals I have had, is that people have prematurely suggested people have post-concussive syndrome, health professionals, and because of people's emotional status or psychological vulnerabilities, poor coping and poor social support, because again, we know those are factors that increase the likelihood of persisting symptoms, they can also be very vulnerable to suggestibility. And what that means is when a person in authority, a doctor, a health professional, makes a suggestion that they have a condition, they latch onto that and they take ownership of it, and that therefore can impact treatment. It can impact recovery, the length of the condition, and these have significant knock-on implications for their well-being. And I guess my regret as a clinical neuropsychologist is that we actually don't get involved early enough. We see people too late in the picture where a lot of harm has already been done and appropriate intervention and so forth hasn't perhaps been taken on board. So we understand it's called a post-concussion syndrome, and we're talking about people who become symptomatic of injury within the first 7, it's usually within the first 7 days, 7 to 10 days, people become symptomatic. And we know that for most adults who sustain a concussion or a mild traumatic brain injury, we know they make a full recovery within 3 months. So if you are seeing someone in that period, it's probably inappropriate to say anything at that point in time because it hasn't been persistent long enough we have to allow a time of normal recovery before we pathologize. And I think that also goes for post-traumatic stress disorder and a number of other conditions. I think we leap in too early. And I think we need to be very careful with making diagnoses. So we have to allow normal recovery. And as all the research shows, the vast majority, it's about 70%, give or take, will make a full recovery within 3 months. And the goal is symptom management, like we need to manage these things. So if people aren't making a recovery, then you have to ask yourself what is going on. And the terminology post-concussion syndrome, it's not helpful, as I indicated, because it's non-specific. It has a connotation of finality, and it doesn't automatically trigger a sense that there's a problem that can be managed and treated and that people can recover from. So now I see the terms persistent or persisting coming up in different reports, and I think I myself probably refer to either or. And again, the language is important because persisting symptoms, it means that they're currently occurring, but it allows that notion that they actually can stop, and also the fact that they can fluctuate. And most people report these symptoms as fluctuating, and persistent has this connotation, A, that it's going to be a chronic course, and B, that it's there all the time. And I think it's really important that we instill hope of recovery, particularly those that get access to people early on in that time, that immediate treatment and diagnostic period. And so we know that obviously there is a normal period of recovery, and if symptoms are still present after around, say, the 3-month period, then we can talk about them being persisting. Ideally, we start addressing the symptoms more immediately than that. So I'm not saying delay treatment. I'm just saying let's be careful with the terms and how quickly we rush in with them. I saw a gentleman recently who had a very, very mild traumatic brain injury, concussion, no impairment on Glasgow Coma scale score or anything like that. I saw him sort of 20 months after injury, and he had adopted that whole resignation, hopelessness, helplessness in all his recovery. He had other things going on, as most people do, as we will see when we go forwards. So we have to ask ourselves what else is in play. It might not be related to a concussion at all. Let's take a big step back, because we know that pre and post psychiatric histories have a huge impact, not just recovery from brain injury, but also in terms of pain. We know that these impact on pain, and often people have these multiple things going on. A bang to the head, a severe bang to the head is often associated with other things going on, headaches, pain, and so forth. And we know that those pre and post psychiatric issues impact pain separate from and including head injury, concussion, so forth. We know that there is impact of medication, stress, substance use, particularly if you think of sporting injuries, recovery from sporting injuries. When you dig down, often there's a substance misuse history in there before and during and after that impacts presentation, treatment, efficacy and recovery, family issues, and we do have to talk about compensation and so forth. So we know that there is a lot going on, and we need to have a look, because there can be coexisting and confounding pathologies. And this is where I encourage people to think below the top of the iceberg that you can see above the water, because the reality is it's everything underneath the waterline. We really need to take a big step back and conduct good investigations and constantly think about differential diagnoses. And unfortunately, I don't think enough clinicians are perhaps conducting a thorough differential consideration. So research consistently indicates that there are a number of factors influencing the persisting symptoms after concussion. We know they increase with age at injury, and I've also said we know that women present with this condition far more than men. We know premorbid mental health is a significant predictor. We know that the development of psychological distress post-injury is significant. And I haven't seen any research on this yet, but after 28 years, I have got a working hypothesis that people of lower intellectual cognitive reserve have a far worse recovery trajectory. And that's because they frequently lack the capacity to make rational interpretations of their experience. They don't often, they struggle perhaps to develop alternative cognitive schemas of recovery around the injury. They often are surrounded by people of similar cognitive capacity, so which means there might be very black and white thinking about what's going on. So it's very easy to fall into an illness mindset, perhaps lacking the capacity to think of other considerations. It's also perhaps impacts motivation and ability to access assistance and so forth. So that's my hypotheses that it's not just pre-morbid mental health history. I also think there's an issue of pre-morbid cognitive capacity, and with that cognitive resilience / psychological resilience to manage as well. We absolutely have to understand that litigation is a factor. I've got it in a slide further down, but I'll preempt myself. The research across Australia and internationally indicates that, up to 40% of people in the medical legal system, so in New South Wales, think of third-party motor vehicle accidents and workers' comp, are making fraudulent claims. They're demonstrating exaggeration and fraudulent claims. We also know that previous head injuries, abnormal imaging at acute stage is predictive. The expectation of a poor outcome, so that self-fulfilling prophecy. And again, this is why the language by clinicians is really important. And I am going to name professions because I've read the medical files, OTs and physiotherapists, inadvertently thinking out loud, maybe you have a head injury or maybe you've had a concussion. It's really unhelpful when you make that thinking out loud in front of a client. If that's what you think, zip it and get someone who's more qualified to review the evidence and make that diagnosis. I cannot, and this is an absolute bugbear, and you know what, I'm becoming an old lady and I don't care if I sound like I've got an opinion. Really, really important not to make those offhand comments. And I say that because I have so many people sitting in this room with me telling me, oh, the physiotherapist said, the OT said, the exercise physiologist said I had a brain injury. Not helpful. And other things going on, of course, extracranial injuries and a high initial symptom load. And that may include other people's distress, like other people not managing their own emotions around the event, family members coming in and doing that catastrophic thinking. The number of people tell me I could have died. When that's clearly not the case, that all gets absorbed by people, and we need to be I think we need to understand those messages that people hear. So, I ask the open question, what's your understanding? What have other people told you? So I'm absolutely looking for that sort of suggestibility that can impact things. At the end of the day, I am a die-hard clinician. I do provide treatment and rehabilitation services, not to the people I assess in the medical legal context, but I am a die-hard clinician. So I always look for the openings of where you can see that there are opportunities for treatment to be commenced, and those little small windows and doors that people mention are those things that can be picked up for treatment. So multiple studies indicate that the most significant predictor is mental health and peripheral body issues and depression. So there are a number of experts that believe that persisting symptoms are caused by structural damage to the brain, and yes, there may be, and obviously in future, as our measures become more sensitive, we actually may be even better at detecting what's going on. So I'm not saying that's not the case. We also understand that a significant number of researchers and clinicians identify more that there are psychological factors, depression, PTSD, and anxiety leading to the presentation. And as I've already mentioned, when we look at individuals who have had a concussion / mild traumatic brain injury and do end up having persisting symptoms, so beyond the 3 sort of months expectation mark, we also find, as I mentioned, that they have poor social support, a lack of coping, and other life stresses going on, and they sometimes have life stresses happening beforehand. So the childcare worker hit by the stick, for example, she had a lot of background stuff going on. There was a lot of issues in her workplace. She was older age, she was coping less with the demands of young children, and I guess that would be seen in the context of the angry outburst by a child. And again, that's a very loaded statement, and I do apologise for causing an offence. My experience looking at the referrals and looking at the language that people use, that people still aren't necessarily aware of the Ontario guidelines, the new changes to the diagnoses in terms of the terminology of talking about persisting symptoms. And my bugbear is that if we change the terms, or we don't change the terms, we can inadvertently contribute to it and decrease the opportunity of treatment. I did say the caveat at the beginning, I'd like to do myself out of a job so I can retire. So let's have a look at what's going on. So we understand, as I mentioned, that there's neurobiological, psychological, and social factors that drive symptom presentations, not just for this, but for other disorders as well. We know that mental health and issues, for example, pre or any of those post, we know they're treatable. So let's get on to that. We know by just putting things into that basket, there might be other things going on that might be missed, so we might assume something. And I actually saw someone on Monday, and they were presenting with memory difficulties and depression, and someone said, oh, they're depressed and having memory problems because they've got complicated grief because their mum died 4 years ago. Now, unfortunately, this person had a non-symptomatic autoimmune disorder that has actually led to significant cerebral atrophy that could have been treated 18 months ago if a more thorough diagnosis had been undertaken. So I saw this person, I'm going, this profile doesn't match a mild traumatic brain injury. This looks like a dementia. Like, this is really, really serious. And I subsequently heard that, because I said this is diabolical, things have to be acted on immediately, that they actually did have something going on, and they haven't had appropriate treatment for the last 18 months. As I said, it can be inappropriate diagnosed. Sorry, I've just gone too fast. And they're not allowing that time for natural recovery, and also there can be overprescription of drugs and so forth. So and then people being told to rest, for example, and then you get that whole deconditioning spiral going on that impacts everything. As I mentioned, we do have to consider validity. So who diagnosed the initial concussion or post-concussive syndrome or persisting, like who was around. I think it's really important. GPs often act as advocates, that's fine, but I think we need to be a bit more circumspect. And because this is largely reliant on subjective symptom reports, I do think we need to get corroborative evidence and actually conduct a thorough differential diagnosis. And because often people say, I've got headaches and that's my concussion, and I've got this tinnitus because that's my concussion. Well, it could be menopause. So I think we need to be very thorough in our interview to make sure that we are picking up the other possibilities as well. If in doubt, refer to anyone with a neuro something in front of their name, neurologist, neuropsychiatrist, neuropsychologist. And given the large number of people that do have mental health issues, it might be relevant getting a good psychiatric assessment going on as well. So I'm aware that we're almost on the half hour. The Ontario guidelines make 96 recommendations. Excuse me, I'm not going to cover them here. You can read the document. But the first one, is about education and expectations. Now, if you may have already picked up, I do have a bit of a New Zealand accent. So in New Zealand, they have a non-litigious system that you have an injury and you automatically get compensation. Now, they did research almost 30 years ago, and they found the best way they could manage concussions, as they were known, concussions and post-concussion syndrome, has always been to provide education, which is basically, you're going to have these symptoms, that's normal, so these are the symptoms, you normalize the symptoms, you say, guess what, that's normal, and they get better naturally. It's really important that you can make a gradual return to your activities when you're feeling able. If you haven't got big migraines, try keeping moving, try gentle walking. They did all of that, and it made a huge dollar impact, as you can imagine. It was profound on the ACC scheme. So that's and this is what the Ontario guidelines also recommend. Not surprisingly, thorough differential diagnoses, review medication and substance use because they come up very high. And the thing that I like, treat specific symptoms. And then that way, guess what? We're adhering to individualized client care. And because it's called persisting, there's no stigma about it. There's this sense of optimism inherent in a diagnosis that, you know, it's treatable, you can move forward, it's not a terminal condition. And so this language is really, really important. And you're building up this expectation of natural recovery, which is what we anticipate. And so let's use the language to support it. And so I do request that we stop using the term. I know that it was previously recommended that it's helpful and keep using it. I'm requesting that we actually stop using the term post-concussive syndrome and we start calling it persisting symptoms after a concussion. And I think I've clearly indicated why I think, and I think that as a group, we can all really assist all those people that sustain these injuries and help them to make the best recovery that they can. So referrals, this goes, oh, they're popping down in different order. Really clear to have direct referrals to the people you think need to be involved, really clear instructions about what you want investigated, informed clients so that they know, look, you've got these persisting symptoms, let's investigate them further. You know, you're giving clear information to everyone you're referring to and supplying the relevant documents. So let's head over to some questions, Michelle.
Absolutely. Thank you so much. That was really terrific. Really, really good. So people, you may unmute yourself now if you would like to ask a question. If you don't know how to do it, you go down to the bottom of your screen and there is a thing that looks like an old-fashioned microphone. Click on it and you will be unmuted and you can speak. Or you can put a question in writing in the chat and we can respond to it from there. Nicola, that was fascinating.
Thank you.
I really liked the pencil with the ball, you know, hitting that person on the head, and the analogy that not every hit to the head results in a concussion, and not every concussion results in lasting issues. I mean, it's so much more nuanced and layered than I had thought it was. So yeah,
we do have an inbuilt crash helmet.
Yes, I know. I was walking my dog a couple of weeks ago in Glebe up a steep hill and I was looking at something and I didn't see a tree branch that was sticking out and I clocked myself with this tree branch, completely fell to the ground. I think I lost a few seconds of consciousness, but I'm fine, no lasting event.
Well, it's funny. I actually talked to a law firm, remaining unnamed, and when I asked the audience how many people here have had a concussion or loss of consciousness, the surprise. I mean, I put my hand up, so again, you know, it was amazing how many people actually raised their hands, donking themselves, doing things. And if you think of what humans, I mean, we've had such a period of peace, but you think in our history and the weapons that humans have used in fighting and you know, just fighting over a bag of rice, we've been clubbing each other for well, since millennium. And you know, when we look at autopsies and things like that, actually, you know, as an aside, people have been doing brain surgery for a very long time. In the Pacific Islands, skulls show people have been doing craniotomies for over 1,000 years. So we have been clocking at each other over the head and not having lasting problems.
Wow. There's a question here. You mentioned PSaC diagnosis being sometimes confused with the onset of dementia. Could you please explain this a bit more?
Right. Well, I don't think I said it could be. I saw a case that was, they thought it was persisting symptoms after a concussion and they clearly had something else going on. Age is a risk factor for persisting symptoms. And the reality is we are living so much longer that, you know, it can be that someone has got the neuropathologies of a dementia going on, and that may even have contributed to a fall or something, and then they have a fall and they bang their head, and people can think that it's a traumatic brain injury, and it might not be, or it may be. They're not exclusive. Like, we've got to stop thinking about everything as black and white. It's not an either or. The reality is, we get to a certain age, we've got a lot going on, including balance problems and maybe a neuropathology going on, and we can fall over and bang our head. So you can have both. Like, it is possible to have a neurocognitive disorder and a concussion. And again, we do know that age is a significant predictor of persisting symptoms. And again, thorough differential diagnosis and a good assessment, i.e., I mean, I don't like, Michelle, I don't like saying, refer to a neuropsychologist, but I can't help myself.
Yeah. Look, that's what comes through, I think, from Debbie's talk and from the other talks that we've had, is the absolute value that is added with a proper neuropsychological assessment. The value is immense in identifying what the issue is, what the injury is, where the person is at cognitively, and what interventions are going to be of value. That is, I see it in my work in the medico-legal industry, and I see what you said as well, that when this is delayed, the outcomes for the person are significantly impacted. People often think, I don't want to put my client through this assessment because they're very lengthy, and they also can tend to be expensive. However, in the context of an injured person with these symptoms, that money is a drop in the bucket in terms of future costs and future capacity of that person to enjoy and live a full life.
Well, you think of the price of a neuropsych assessment compared to someone being off work for 18 months. I mean,
100%.
It's ridiculous. The other thing that people, I'd like to impress upon it, as neuropsychologists, we do investigate anxiety, stress, depression, and all those other things. So you actually get you get a lot of bang for your buck, because we do the brain and we do the psych, and we understand how they are interrelated. So we are, we're very good at teasing out the different contributing factors. And we spend so long with people, I don't like to consider myself a pedant, but we are, my clients say, gosh, you ask questions that no one else has asked me. I mean, that's part of our training. Our interviews are 2 hours before we start anything else. I mean, we are very, very particular about the information we get, that we know that can impact upon brain health, pre, post, during, everything.
Absolutely. Look, we'll let everyone go, because this has gone a little over time, but this was fascinating. On behalf of MAG and of all of the people who've listened to this, I thank you very much for what is surely going to be one of our most visited sessions for a while. Thank you to everybody for making time for us. Look forward to seeing you on our next seminars coming up. Thanks so much, Dr. Gates.
Thank you.
Bye-bye. Let's stop that recording.
All right. Thank you.